Good evening, everyone. So, shall we start the class?
Yeah, we shall start.
So today's topic is trauma and burn. It will be a CBS session, and it will be taken by Dr. Sangshaptak Saha, sir. So you can continue. Thank you.
So the basically last class we discussed about trauma, burns, and bit of drowning, and we already discussed the long case scenarios. From burns, basically there is only one scenario that can come. That is the fluid calculate that we discussed last session on fluid calculations and about the poisonings, right? So this session we shall mostly be focusing on some of the the CCS the on the trauma section, and we shall also be discussing a the bit about the CT scans. So we shall first start with the CT scans actually. So we can do it two ways. One is that which I shall prefer is one of you shall unmute yourself and shall answer to the question, whatever it is, description or whatever. And if you guys do not want that, then I can read out the question, then one of you can answer. And just be a bit quick because you don't want to lose that valuable time behind, waiting and me asking somebody and those things. So if you guys take a bit more time, then I shall just give out the answer with the explanation, just to focus on the time, because we shall be discussing the CT abdomen, a bit of CT chest, the trauma part, and a CT head, and we shall also be discussing a bit about the 2-3 aspects of trauma also. Okay, so we shall start right now. So one of you just unmute yourself and okay. So it's a 41 years old man post RTA who was admitted ED. He was fluid resuscitated, and in view of the EFAS positive, he was put on MPP protocol. This is ECG after 12 hours. So just diagnosis and first 2 steps of management.
Hi, sir.
Hi, doctor.
Yeah, I'm driving, but I could see the ECG while I'm driving. So this is Osborne sign on the ECG. Looks like hypothermia. So the management of active rewarming of the patient while doing the resuscitation. He's positive. He's having positive EFAST. So and I need to look at the hemodynamics with the resuscitation with blood and blood products.
So doctor, tell me in the management of hypothermia, what is our temperature target?
My temperature target is 37.5.
Okay, so what is your goal of the in this situation? Like, is it to prevent hypothermia, or is it to maintain a normothermia, or is it something else?
Normothermia, and active normothermia, definitely to prevent hypothermia. But my target will be 36 to 37. Let us say that,
Okay. Absolutely. So, can you tell me a few other scenarios where we are practicing hypothermia in our ICU?
So there is, so post-cardiac arrest, which is debatable.
Yeah.
In the last,
can you tell me the name of the trial behind that? The post-cardiac arrest hypothermia trial.
Eurotherm trial.
Okay. Anything else?
No, I can't recognize. I don't remember, to be honest.
Okay. So the post-cardiac arrest hypothermia, a temperature-related trial is a TTM trial, right? The Eurotherm trial is also one related to hypothermia, as Dr. Mena said, but that is mostly in TB in the trauma patients. Okay, and there is also the polar trial. So just remember these names of these trials because the names can be asked regarding hypothermia. And as Doctor said, it is Osborne waves. One of the commonest complication of this question is that people do not go through the question. They just see it and tell that there is an ST elevation or some other things, TUF depression, something like that. So yeah, go through the question. He was fluid resuscitated, EFAS positive, MP protocol, massive blood transfusion. So hypothermia has occurred. Question number 2. Nothing much. 32 years old lady, RTA, EFAS positive, USG shown. Just tell me the diagnosis and the management.
So this is also positive fluid collection in the Morrison pouch. And in the context of trauma, this is supposed to be hemoperitoneum. So management, I will need to consult resuscitation, ABCD approach, and I need to call the surgeon, acute care surgery, for possible urgent laparotomy if the patient is hemodynamically unstable.
And you need to arrange blood products also, right?
Yes.
So the thing about this question is that everybody knows what it is, but in a limited time, you need to tell at least 3-4 things. First is you need to look at the ABC. Second is surgeon, laparotomy, that part. Third is arrange blood products. And what are the 3 things that you will like to look at or prevent in this acute trauma patients?
What's your question, sir? I
Acidosis,
didn't get
acidosis, coagulopathy, and hypocalcemia.
Yeah. So the question was, what are the 3 things you look to prevent in an acute trauma patient? And this comes with practice. Once you are asked this question, you need to realize that the question that the examiner is asking about triad of death or the fatal triad. Yeah, the lethal triad, and you need to answer that. And hypocalcemia is not a part. It is in the latest guidelines. Hypocalcemia is included, but in lethal triad, it is coagulopathy, metabolic acidosis, and hypothermia
and coagulation.
Yeah. 49 years old bus driver had an RTA. He had severe upper abdominal pain with high lactate. CT done, and this is a CT. What is the diagnosis and what type it is?
Dissecting abdominal aneurysm.
Dr. Menas, we have discussed this question previously. You gave the exact wrong answer then. It is an aortic dissection. It is not.
The aorta is behind the spine. This is, in front of the spine.
Yeah. So just try to concentrate. It is not.
This is IVC, I think.
Yeah, it is an aortic dissection. Don't give the answer as an dissection of aortic aneurysm, something like that. No need to mention aortic aneurysm. It can be a straight cut aortic dissection. It is post RTA, right? So it may not be an aneurysm to begin with. Okay. So what type it is? What type of aortic dissection it is? What is the location? Which part of the aorta?
Type 1.
Why?
Because it is at the beginning of the aortic arch, ascending aorta. You can see the bifurcation of pulmonary artery over there.
Yeah, so it is involving mostly the ascending aorta or the arch of the aorta. So what is the classification? How do you differentiate between the two?
Stanford classification, type 1, type 2.
Yeah. And there is also DPX classification, but any one of them is fine. And what is the management of this type 1 or type A?
Type 1 is surgical management, and type 2, if you control BP, and can be medical management also.
What is the pulse and the blood pressure target in a case of aortic dissection?
There can be differential blood pressure in both the upper limb, right and left. So there can be more than 20 mm Hg difference.
I'm not asking that. I'm asking about how much blood pressure you keep in this patient. What is the blood pressure?
Okay. Less than 160/90.
No, doctor. 160/90, absolutely not. Aortic dissection, the blood pressure target is less than 100, around 110, 120 range. Okay, 160/90, I think is you are talking about ischemic stroke. Aortic dissection, you have to keep it much lower, 110, 120 range for SBP, and the pulse rate with beta blockers at least around the 90 range, not more than 100.
Okay.
So this is a 17-year-old boy after a brawl had severe back pain and fainted. His GCS is now 12. CT scan is shown. So what is the CT scan demonstrating?
ECG to abdomen. There is looks like a splenic rupture, I guess. There are some hyperdense lesions in the spleen.
So, doctor, I am sorry, I can't see your name here, but yeah. So, what you are telling is absolutely correct. But in the EDIC part 2, they also mark you on the basis of how you approach. So, the way you are telling, it seems to me, a person who doesn't know you or at what post you are working, things like that, it seems to me that you are not very confident. Okay. So, that should
Okay.
not be appearing in the exam. I mean, you are telling absolutely correct. It is a CCT abdomen, there is a splenic injury, there is a collection. Of course, there is a hemoperitoneum also. So you need to tell him that, na. You don't need to hesitate and tell. You see, the
Okay.
question is this, right? It's a severe back pain, fainting after a brawl. So the clinical picture is correlating with what you are thinking of in the cities. Not that you are telling something absolutely out of the ordinary. It's one of the
Okay.
commonest CT scans that can be asked in the exam, and you're telling that. So behave like that.
Okay.
Yeah. So that's the point, because all of you who have joined, that 12, 13 people you have joined, I am sure you know the answer to this. All the 3, 4 people you discussed is how you approach and how you tell about the question. So you need to tell that this is a CCT abdomen, which is showing a case of hemoperitoneum. There is collection in the abdomen, and there is a splenic injury, and we can see that there is a extravasation of the contrast in the abdomen, and so there is a shattered spleen. So this patient needs a laparotomy and a surgical surgical
Approach.
advice
Splenectomy.
and a laparotomy after constant and blood product, those sort of things. And then you will be asked maybe 1 or 2 questions on the metabolic acidosis and the lethal triad and massive blood transfusion. Just 1 or 2 questions. If you if you fault on the initial city, the description, they will ask you 1 or 2 questions on that, which they will
Okay.
mark you, because they cannot mark you on extra question that they're asking, because everything is pre-decided, right? You know that the question,
Yes, sir.
answer, everything is given to them, so they can't mark you anything beyond that. And then they have to ask you the other questions also. So you will be losing time and probably will miss 1 or 2 questions later which you would have answered.
Okay. Okay.
So in these things, it's not about the question. The question will be straightforward, easy questions, but you need to manage the time. Anyway, so next question: 56 years old driver post sudden halt to a car. He presented with a speed of 80 kilometers per hour. He presented to ED with lower limb weakness, dizziness, cold, clammy extremities. His GCS is altered. BP is 90/50. So tell me, without looking at the CT scan, what do you think has happened in this? A CT abdomen has been done. So what are you expecting to find?
Spinal injury, spinal shock, or neurogenic shock.
What is the last point? Spinal injury or?
And neurogenic shock or spinal shock.
Okay. Anything else? On a CT, CT you won't be able to find a. You would have a CT abdomen, so you won't be able to find out a neural shock, right? I agree
Yes,
with you.
sir.
It can be neural shock, obvious. But a CT abdomen, what can be the finding which will help you to clinch the diagnosis?
Vertebral fractures you can find.
Yeah.